Turkish Continental Society executive, and especially to Tafan Tarkan for this. Well, before starting, well, these are my conflicts of interest. I have to say that before talking about what is new, we have to talk about what is old. And this is a very nice car, but we recognize that it's old. And maybe that the concept of aging and the concept of the need of testosterone inside in blood levels is necessary to develop BPH, and we know that this is an old concept, but perfectly works. Of course, this concept, it's again a very well-known concept. We need this testosterone inside to enlarge the prostate, to become a bladder outlet obstruction, and of course, finally, acute urinary retention, and all of the changes in lower urinary tract dysfunction due to this obstruction, of course. All of these concepts are indeed old. We know that we have the concept of histologic BPH. We need the concept of Lutz bladder, BPH enlargement, and obstruction. And of course, all the concepts may be in conjunction or alone. It's necessary to be together. The unique concept some years ago of benign prostatic obstruction leads to LUTS. It's nowadays not completely valid because we know that there are a lot of other etiologies, a lot of other mechanisms that can be together and cause these LUTS. But we know this from many years ago. So what is new? From my point of view, I think that it's new that we have to leave the concept of thinking only on BPH, and we have to think another organs, another concept, another pathophysiology that can lead to male LUTS, of course. We have to think, and we'll talk in the next minutes about metabolic syndrome. We'll talk about the different configurations of the prostate, just to produce obstruction or not. Of course, we talk about inflammation, the role of inflammation, and bladder ischemia, and we talk about the drusen changes that can lead to the drusen overactivity or can lead to underactivity. And of course, the different systems, neuroendocrine systems, that can have some relevance in developing BPH. Let's move to talk about metabolic syndrome. Of course, the definition is 3 or more of these: hypertension, obesity, of course, dyslipidemia, or hyperglycemia. Of course, this is an epidemic situation because if we see now in men of 50 or more in the United States, almost 1/3, even more, are suffering from metabolic syndrome. And if we look at this, one of the first studies, there is a direct linkship between diabetes and hypertension with LUTS. And there is an increase of 80% of having LUTS if you have 3 or more components of metabolic syndrome. And if we look only for obesity, this is a very nice study with 18 years of follow-up in men, more than 18 males. We found that there is increased risk of LUTS from 30% to 60%, more or less 45%, when we have more body mass index or waist diameter or weight gain. And not only for the risk of LUTS, for the risk of increasing the volume of the prostate. We know from different studies, this is a systematic review that shows that there is a logical link with the increasing age, but there is another link with increasing waist diameter. So look at your waist, please, all men, because we have to be careful about that. And we have to look about our levels of HDL cholesterol. So as they decreases, there is an increase in BPH. Of course, why? Because we have increased estrogens with metabolic syndrome, we have increase in LDL and oxidative LDL, and those makes in the prostatic myofibroblastic cell a release in interleukins, in pro-inflammatory interleukins, and there is an increase in fibroblastic growth factor that goes to increasing the risk of BPH and progression and enlargement of BPH. This is the logical things that can occur if you have a metabolic syndrome. And of course, we can reverse that with age. Of course, we know that with age you have more odds ratio of having LUTs, of course. And if you have a high body mass index, there is increased risk of that. But you can decrease that risk with exercise. So we know this from this study, very nice study. And there you can even, with exercise, regular exercise, so easy like a daily walk, you can decrease the chance of LUTs in 20%. So, metabolic syndrome is a complex in the pathophysiology of BPA and LUTs through the insulin resistance, through the hormonal changes, and pelvic arteriosclerosis and inflammation. Those with different mechanisms, finally you have the incidence of LUTs or BPH. And more complex things, and we have to change our way of thinking. It's not only a question of having an enlarging prostate. If we are obese, we have more chance of having stroptic sleep apnea. And of course, this leads to changes in nocturia. This increases the chances in nocturia, just increasing the production of ANP. And of course, nocturia in itself, the disruption of the sleep in itself, increases the risk of metabolic syndrome. So we are closing the circle with all of these phenomena. So what can we change in the future? Of course, there are some non-modifiable factors that we can change, like genetics, ethnicity, the age of geography, where you are born or you live. But some of them are modifiable, like obesity, we can fix it, hormones, diabetes, diet, physical activity. Generally, changing this metabolic syndrome to look like this in the future. That's what we have to try. But just thinking about the pathogenesis of BPH, well, we know from many years that androgens, estrogens, of course, these epithelial and stromal interactions, the growth factors, and different neurotransmitters play a role in BPH and play a role in the LUTs. Let's think about the hormonal regulation of BPH. We know that the main hormone is the dihydrotestosterone, and we need this 5-alpha reductase to transform testosterone inside the cell in dihydrotestosterone. So this is very important. We know that all the 5 ARI are valid treatments for this, but we have to think that maybe even metformin is a new drug that can act over the insulin growing factor receptor. And we know that this insulin growing factor receptor has a paper in the downstream genes and just producing stromal proliferation. So we can block that from this way. And there is very recent news that using for long-term 5-ARI treatments may produce diabetes type 2 in men. So maybe in the next future, we have to rethink what will be our treatment for men with BPH. Of course, there are some other mechanism that happens inside the cell. Of course, there is an hypertrophic basal cell, but altered secretions inside the luminal cells led to calcification, inflammation. Of course, there is a production of pro-inflammatory cytokines due to this inflammation. And there is phenomena of increased radical oxygen inside that produce cell damage, and increase in basic fibroblasts and tumor growth factors production. So that those led to stromal proliferation. And of course, there are changes in autonomous innervation and changes in neuroendocrine cell function. So those of these local, very local at the level of histology and the epithelium and stromal interactions can lead to growing of the transition zone. Of course, prostate inflammation can be down due to a virus or bacteria or even this metabolic syndrome. And this cell damage go to an inflammatory response, and these myofibroblastic cells have a major role. Just releasing this interleukin 8 that has been found in many studies that can lead to this growing stromal in the transition zone. Of course, and this is very new from many years ago, but this is a renewed interest on that. It's not only a question of size of the prostate. We have to think about where the transition zone is developing, where is the adenoma developing, because we have to look at the position of them, subcervical or those with the median low. There is a big change in the function and in the hydrodynamics of the micturition. So this is a new thing, some pathophysiology we have to think about. And some years ago, there are new actors in this scene of growing of the BPH, and serotonin is a new actor in this. This is a very nice study from Portugal, and shows that serotonin can inhibit prostate growth through downregulation androgen receptors. This is the normal state. If you look, you have the epithelium upside, you have the stroma downside, and you have the vessels at the bottom. And there is an environment of testosterone, but there is also as well an environment of high levels of serotonin in the stromal and the epithelium. This serotonin is produced by the endocrine cells, and these neuroendocrine cells that are between the cells in the epithelium are producing these levels of serotonin, and serotonin is downregulating the expression of the androgen receptor. So the androgen receptor is blocked by serotonin. That means that when you are young, the serotonin levels inside your prostate are protecting you for growing this prostate. But what happens? When you become older, these neuroendocrine cells go down. There are lower level of neuroendocrine cells, so you have lower levels of serotonin. That means that even having low levels of testosterone, there is no blocking in the receptors, and so you have an overexpression of the androgen receptor. That means an epithelial proliferation, or it means an stromal proliferation. And we have to keep in mind more factors, and one more factor is nocturnal polyuria. This is very new for many of us, and it has become a new actor in the lots of males. And we have to think about nocturnal polyuria in terms of sleep obstructive apnea, cardiac problems, of course, diabetes, and these problems in the metabolism. We have to think about kidney problems, and we have to think about sleep disruption and how it can influence producing nocturia. And of course, we have to think about lower limb edema. So there is many factors that can lead to nocturnal polyuria. We have to think in many different pathophysiological mechanisms that can lead to nocturnal polyuria. So we have to change, because these are all the different factors we have to keep in mind to treat a patient with nocturnal polyuria. But only the orange one is urology, for the urology. The rest of the different components came from internal medicine, from other specialties. But the patients came to our consult just to the urologist, not to the internal specialist or to the neurologist. So we have to learn about nocturnal polyuria, because this is one of the most important symptoms. Of course, pelvic ischemia, and of course, the Fantarkans have experience of those kinds of investigation. But we have to think that pelvic ischemia is not only due to metabolic syndrome. It can be secondary to benign prostatic enlargement, because of low compliance of how the trussal pressures can lead to low levels of vascularization in the bladder. And if it's real mild, can lead to the tussle activity only with the storage symptoms, but if it is severe, can lead to changes in the trussal function and changes in histology. As you can see in the middle, there is a lot of blue. This is a trichromic stain, and that means that blue is fibrous tissue, mainly fibrous tissue, collagen, and that means that there is a low level of muscles, fibers, and that means that this muscle is more closer to underactive detrusor than to overactive detrusor. That currently happens after a chronic obstruction or chronic ischemia. Finally, we have to think about risk factors, and thinking about pathophysiology is not only an exercise, an intellectual exercise, it's also as well an exercise of looking about the future, about treatments, about what can we do as urologists. So there are some of them factors that we cannot change, but we have to think all of those factors that we can to change. We can counsel our patients about changes in lifestyle, and of course we can treat those conditions that can be treated, that can change the future of our patients. Of course, recommending new lines on treatment as they will come in the future for sure. Thank you very much.